it's important to be able to pull a sample population from the population at large. You can do that through all different methods of recruitment. You're going to collect the baseline information. We looked at single center, multi-center, international type studies, and the different bias or the different randomization schemes available. We looked at this being the block randomization. And the next component to minimizing bias, we want to be those Ghostbusters. We want to sort of keep that bias at bay, keep that to a minimum. How do you do that? One of the ways is through blinding. There's what's called single blind, double blind, triple blind studies. Single blind studies, who is blinded in single blind studies? The patients. Who is blinded with double blind studies? The patients and the investigators, the researchers. Triple blind refers to essentially where everybody else is blinded. So people who are just reviewing the data. It's sort of, I don't want to say it's synonymous with double blind because it means sort of additional blinding people. But typically when you think double blind, you think of sort of the lowest level of bias because the investigators and the patients are blinded. And triple blind is just referred to then, sort of everybody else blinding. And I'll give you a quick example why I think that blinding sort of could impact this study. And the example was when I used to work in the investigational drug service, the nurse would come down and she would pick up a study drug from the pharmacy. We would compound that drug, give it to the study nurse who would go upstairs and administer it. If it was a placebo, it was no problem. We just put the normal saline or whatever it was in a vial, and we gave it to her. If the patient had to be randomized or happened to be randomized to the active drug had a really short shelf life. So the drug would start to sort of break down rather quickly. So you would have to get it to the nurse. You would have to get it hung, and you would have to get it administered, infused, sort of within 30 minutes of the moment that the drug was that it was compounded. So you can think of the situation: pharmacy is compounding it, nurse comes down, it's a placebo. The pharmacist or the technician talks to the nurse. Hey, how you doing today? You excited for the Super Bowl? How was your weekend? It was cold outside. The nurse then may become aware that maybe it's a placebo. I mean, again, the reality is, versus the nurse comes down and the pharmacy is all shooken up and compounding it. Hold on 1 minute. Just let me focus on this. Let me get this thing done to you. Let me give you this medication. Again, you have 30 minutes to go and hang this. You see how sort of very different, again, it's not an intentional approach, but that alone, I think, would sufficiently be able to trigger to anybody who's receptive. And then the same thing with the nurse. The nurse is going to go up and talk to the patient. Oh, how you doing? Is this your mom? She's so nice to come with the flowers. That's good. You feeling good today? Versus, where's that IV line? Let's get this hooked up. Everybody get out of the way. Let's start to administer this. Okay, it's 10:14 now. Let's start to continue the medication. So, all of that creates sort of just an inherent bias into the study. And in this example, triple blind would be perhaps where the pharmacist could be blind. In that example, would that pharmacist be able to be blinded? Maybe, maybe not. You can have sort of one vial of a placebo, one vial of the medication where, the pharmacist is going to be blinded. And actually, in that study that I was referring to when I worked in the investigational drug service, a triple blind study would have been even more preferred than the double blind study, because the triple blind, that pharmacist would be blinded. So the pharmacist would be consistent if they were administering the placebo or the active medication. Open label just means sort of everybody knows what they're getting. The physician knows, the investigator knows that it's what the medication is, and the patient knows. So sometimes there may be a need or a study design where it's open label. Open label means that the patient and the investigator know what the medication is or what the active treatment arm is. And unblinded refers to after a study, oftentimes they unblind it. So they'll tell the investigator, oh, this patient did get the active medication or the control, or the patient would be unblinded, say, oh, you got this medication, you were randomized to the active control as opposed to the control group. So when you look at controls, typically placebo control is the optimal control in a study because it controls for that placebo response, which typically about 30-40%. However, as we talked about the World Medical Association in their Declaration of Helsinki, they're not so big on placebos because if there's active medication, it is hard to make a good moral argument why patients should be getting a placebo. So oftentimes you do an active control, and if we're going to do vitamin C12 versus vitamin B12 for the common cold, that would be sort of an active control. So you would use your vitamin B12 as your active control. A placebo, you would just give your vitamin C12 versus a placebo. And ideally, the placebo would resemble everything in terms of its appearance. The pharmacological effect would be, of course, completely different. However, it would mirror that appearance. Double dummy, which we'll look at momentarily, it's a way to control for an active control that is perhaps a different formulation. And the example is vitamin C12 is an oral medication. Vitamin B12 is an injectable. If you want to study vitamin C12, which is an oral medication, versus vitamin B12, which is an injectable, how can you set up that study where patients are blinded? And we'll come back to that. An internal control is where you're matching control. So if we when we talked about the randomization scheme, when it's the minimization, where based on what you know about the patients who have enrolled, you're going to try and enroll a new patient to offset or minimize any differences. Question?
If you're testing a drug that could be taken orally and you're testing it compared to a drug that's injectable, could you possibly get placebos for both an injectable as well as an oral?
Yes, exactly. And we'll illustrate that in the next slide. And then you've got your external controls for whatever reason. If vitamin B12 perhaps is on short supply, or there's data that shows excessive use of vitamin B12 causes adverse events, but we want to sort of use that as the control, maybe we'll just go back and we'll use patients who've already received that medication. So again, it's sort of that retrospective control group, which we realize that any time we go retrospectively, we go back in time, we lose a lot of control over the study. Or you could do no control. You could just give 100 patients vitamin C12 and see how they respond. But what's the problem with that? If 50, 60, 70, 80, 90, 20, 10, 39 patients respond, how do you interpret that when you have no control group? So real research requires a control. Why do you have a placebo? It accounts for that placebo effect. Avoids treatment with an investigational drug. So half the patients get the drug, half the patients will get the placebo. We don't know about the investigational drug. It may be harmful. It may cause increased side effects, facilitates blinding compliance, and really it provides that basis for comparison. We looked at sort of the ethical considerations. It's really sort of useless in practice, even though there is a placebo response of 30 to 40%, but oftentimes physicians, pharmacists, again, we'd rather not treat with placebos. I think we'd rather understand what the underlying issue is and treating that. And the placebo interferes with that accurate estimation of effect size. It helps with it, but it sort of complicates it as well. So if 50% of patients improve on vitamin C12 and 25% improve on vitamin B12, what percent of patients are responding to C12? Is it that 25%, that difference? Is it 50%? Because that's how many people respond, however, based on a control. So, just understanding this. And here's your sort of example in what we call a double dummy study. Double dummy is the use of multiple controls to maintain blinding. So here you've got your vitamin C12, your oral, and your vitamin B12, which is injectable. How do we compare this? Because if you walk into the pharmacy and we give you the red pill, we know you're getting the red pill. If we give you the blue injection, you're getting the blue injection. It's difficult, if not impossible, to blind those two. So what we do is we set up a design where we use multiple controls. So in this example, you would get the actual patients would be randomized to receive the red pill or let's do the blue injection. They would get the blue injection and they would get a red placebo. So they would get the injection plus they would get a red placebo pill. And on this side, they would get the red pill and then they would get a placebo injection. So that's called a double dummy, and it actually is very intelligent, very smart, makes a lot of sense when you're comparing different formulations, different color medications, things like that. The problem is if red has a metallic taste, there's not a lot you can do. So, there's ways that people become unblinded to something. Patient comes in, they say, "Doc, I'm taking this red pill and I keep getting this metallic taste in my mouth." The doctor is going to be smart enough with the pharmacist to say, "Oh, you're getting the red pill." However, if there was, if that was sort of an inactive ingredient, maybe you could put that metallic component into the placebo, but if it's the chemical moiety, it becomes difficult. Typically, when we talk about the studies that we're looking at, we call them parallel studies. Just two parallel groups. The experimental group gets the experimental drug, the control group gets the control group. So we take this group here as representative of the population at large. So if there are 100,000 people that have the common cold, we're not going to be able to study 100,000 patients. Would we like to study 100,000 patients? There's going to be benefits and disadvantages. The benefits, we're going to know everybody who has the common cold, how vitamin C12 versus vitamin B12 will work. However, it's going to be expensive. What happens to patients who have the cold, and then by the time you get in the study, their cold is already improving, and you have patients who are getting sick during that period of time, you're going to lose those. It's sort of a moving target. So what we do is maybe we take 100 patients. And how do we determine what number of patients we take? If it's 100, or if it's 1,000, or if it's 500. This is that baseline assessment to see if you guys have you taken research design statistics yet? So how would you determine how many subjects you would enroll in that study? Because again, there's 10,000 patients that have the common cold. How many do we want to study? 50, 100, 250, 500, 1,000, 5,000?
We would want to look at the effect size.
Exactly. So one, you're going to look at the effect size, which is then going to calculate what's that statistical term called? Power. So you're going to have to know the effect size. Does this thing cure the common cold in 95%? Because if it does a really high number, are you going to need a lower number of patients or a higher number of patients? If the effect size is large, you're going to need a larger number of patients or a smaller number of patients? Smaller. If the effect size is really small, are you going to need a small size of patients or a large size patient population? You're going to need a large size to detect that very minute difference. So you're going to have that effect size, and ultimately the word is power, the ability to detect the difference. So that's how we're going to do. So here we power our study, and we'll go into more detail about that, and we'll say we need 100 subjects. So we give 50 the active drug, 50 the placebo, and then we measure our outcome of interest, whatever it is, the cold scale. We have people come in, are you cold? Yes or no. Do you have a cold? Yes or no. And we can then compare the differences. Crossover studies are different than parallel studies. Crossover study, we get whatever number of patients based on the effect size, based on our power. So we have 100 patients. 50 of them get drug A first, and then they cross over to drug B. So if we're talking a placebo, maybe they'll get vitamin C12, and then they'll get a placebo. Here, patients will get a placebo, and then they'll cross over to vitamin C12 in phase 1 and phase 2. crossover studies have some problems compared to parallel studies. They're the period effects, the sequence effect, and carryover effects. So in a period effect, influences that vary over time. And that's sort of like the cold. The cold basically comes and goes. So patients who are going to take the first drug are probably going to look effective. By the second drug, they'll definitely be effective. So based on just sort of the timing. And then some things have a sequence. If, say, patients with arthritis, that may just get better over time. But if you give an NSAID versus a disease-modifying drug, that disease-modifying drug first may have an impact on the disease. Then when they get then the non-steroidal, they're going to have a wonderful, wonderful cure that'll look like perhaps from the NSAID, whereas really the effect may have been the disease-modifying product. And then you've got your carryover effects. You know, what sort of the half-life of the drug. If patients get vitamin C12 and then they cross over to vitamin B12, is there going to be any carryover of the first drug, vitamin C12? Typically, how many half-lives does it take to get rid of a drug? 4 or 5 half-lives. So typically, if you take vitamin C12, you would want to wait maybe 4, 3, 5, 6 half-lives. The longer you wait, the more likely you are that the drug will be eliminated, so you don't have that carryover effect. So just understand that parallel studies just sort of run parallel crossover studies. The patient gets one drug, one treatment, then they cross over. There's lots of benefits to that. You need less patients because the patients are serving as their own what? Patients are serving as their own control. There's decreased variability because that patient is that patient. You're not comparing that patient to another patient, somebody different. So there's less variability, less patients. It has a longer duration, which is problematic because you're sort of multiplying the time times 2, but you're cutting the patients in half, which is nice. And then it's more intolerant to patient dropouts because if a patient drops out, guess what? You lost the control and the active arm. Whereas parallel studies, you have increased variability because you're comparing different individuals. A shorter duration requires more patients, more tolerant of missing data, and no period, sequence, or washout effects. And again, you know, there's nothing, it all depends what study design you should use, how you approach things, but understand that there are definitely times for crossover studies. And there are times for parallel studies. If you're doing something like a bioequivalence study, you would want to use the same patient because you would really know on that patient. Because if you do a bioequivalence on a patient and then you want to compare them, maybe the same age, the same weight, the same race, but you know, how do you get down to the molecular metabolic level? Maybe some patient's going to metabolize that drug faster or slower based on some genetic predisposition. So in that example, maybe a crossover study would be optimal to help you establish the bioequivalence. Oftentimes, you'll read in a study, it talks about a run-in phase. Run-in phase, just synonymous with pre-randomization. Before patients are sort of randomized to it, they'll run them into the study. And what they do, we just have 100 patients. We're going to randomize you to active and control group. We have 100 patients. We're going to randomize you to active and control group. But let's get you in the study. Let's measure your height. Let's measure your weight. Let's see if you're going to show up to your appointments. If people don't show up to their appointments, are you going to keep them in the study? No, you're going to exclude them. They may give them a placebo medication. Here, I want you to take this every day for 10 days and come back to your appointment. And if they don't come back to your appointment, you're not going to include them in the study. If they come back and say, here, I took all 10 of my medications exactly at 8 a.m. as instructed, is that a patient you're going to include? Yes. If they say, I took 9 of my pills at 8 a.m., are you going to include them? What if they say, I took 8 of my medications at 8 a.m.? What about 7, 6? You have to sort of, again, there is an art to all of this. There's not a science. You have to arbitrarily determine what is okay with you? How do you measure adherence? How do you measure placebo response? The patient comes and says after 10 days, I don't know what you gave me, but I feel great. I am cured. Thank the Lord. I am moving on. Maybe that's a patient you don't want to include in your study. Maybe that is a patient you do want to include in your study. Patients who, come and say, oh, I feel like horrible. I don't know what you're giving me. My body's not responding. All of that. It allows a washout period. If patients have been taking other medications, if they've got the cold and they come in and they're taking Airborne and they're taking vitamin C and they're taking zinc or whatever it is, you say, okay, during these next 10 days, I don't want you to take any medication. So when we start the medication on day 11, you're going to be clean. How long a washout period? Again, 4 to 5 hair flies. Measures adverse effects, obtain necessary data, ethical considerations. Not a lot of ethical considerations, not a lot of worries. And then what are you going to measure? If we're going to measure the common cold, if we're going to check vitamin C12 versus vitamin B12 for the common cold, what's the most, I don't even know, what's the optimal measurement for that? I'm sure there's a scale. If anybody Googles, cold scale, common cold scale, severity of whatever, quality of life, there's all different scales. And when you do a study, you want to set up your hypothesis, your null hypothesis, with the proper measurement, the proper instrument, so you can detect that difference. If you do something like diabetes, it may be easy. You're going to look at blood glucose levels. If you're looking at a new hypertensive drug, it's going to be very easy. You may want to look at hypertension. If you develop a new drug for hypertension, what's the optimal outcome that you're going to look at? What's that? It's not blood pressure. I'm making the argument. Not blood pressure. If you come up with a new drug to lower blood pressure, really what doesn't matter is blood pressure. So what matters? What's that?
Whether the patient dies.
Yeah, right? I mean, would you rather walk around with low blood pressure, your blood pressure's under control, and die in 6 months from whatever? Or would you rather have quote-unquote high blood pressure and live to be 109 years old? Blood pressure is considered what type of measurement? It's a surrogate endpoint, surrogate measure. So surrogate measures are great. Again, I'm not making the argument that we wouldn't care about blood pressure, but blood pressure is a surrogate measure. It's something, an easily measured endpoint used in place of a more meaningful endpoint. And with blood pressure, what we really care about is heart attack and stroke. That's the clinically relevant outcome. Diabetes. Blood glucose really doesn't matter. What matters in terms of outcomes for diabetics? Morbidity and mortality. Do they live or do they die? And maybe what's their quality of life? Amputations, kidney failure, heart attack, stroke, eye problems, vision loss, neuropathy. Those are all awesome outcomes. Whatever their blood glucose measure is in the morning is important because, we anticipate, we expect, we want that to be representative of other long-term outcomes, but it may not be synonymous with that. So we have to figure out what the appropriate instruments are. What are we going to use to measure? And we talked about this a little bit last week when we looked at blood pressure. In Puerto Rico, they may use a different type of sphygmomanometer. They may use a different cuff. Individuals in Florida may be trained differently than individuals in California as to, what to inflate the cuff to. So we want to make sure that everything is standardized, sensitive, specific. We're able to detect the outcome that we're looking for. We want subjective or objective outcomes. We want objective. So again, that minimizing bias. Because if it's subjective, the patient will have an influence, the researcher will have an influence. That doesn't seem very good. Surrogate measures are not optimal. Oftentimes they're preferred because they're easily measured, less expense. I mean, time and money are always important in research as well. And then your endpoints. Do you do a priori endpoints or a posteriori? Are we planning the endpoints in advance, or are we just going to bring the patients in, give them vitamin C12, give them vitamin B12, and then we're just going to ask them 100 different questions and see what's different? Oh, you feel good today? On Saturday mornings, on the days you eat brunch, you feel really good. As opposed to, what's planned. We're going to give you this quality of life measurement every morning for 10 days and see how your cold symptoms improve or don't improve. Primary versus secondary measures. Oftentimes when you set up a study, you want to know, does this drug do this effect? That's your primary outcome. But since you're going through all this time and expense, all this effort, oftentimes you'll do secondary endpoints. So the diabetic, maybe we'll power our study based on effect size. We'll get a sample size of 500, whatever. We want to figure out, does this diabetic medication decrease, say, hemoglobin A1C? What's the problem about doing, will this anti-diabetic medication have impact on, say, heart attack or stroke? Why do we do hemoglobin A1C, not heart attack or stroke? It's easy to measure. Well, actually, I would argue that heart attack or stroke is much easier to measure. The immediacy of that. If we're going to look at heart attack and stroke, we may have to have patients in the study for 20, 30, 40 years. Whereas hemoglobin A1C, we need them in the study for how long? 3 months, 90 days. We'll be able to get a hemoglobin A1C measurement to measure a difference.
But what about the databases that has years worth of clinical data on patients who fit those conditions?
Right. Again, all of that stuff is available for historical use. Historical data, again, the argument is it's great because you've got vast numbers of patients who have perhaps taken vitamin B12 for the common cold. We can go back. The problem with that type of data also, we don't have the quality control. We are not sure that we had the most standardized, sensitive, and specific instrumentation, the testing. Maybe one of the quality of life questions changed 15 years ago or 3 months ago. Or maybe the individual who was administering that based on their own bias can impact how a patient responds to a certain question. We'll look at composite endpoints, multiple endpoints, subgroup analysis. The point is that when you do a study, you're powering it toward your primary outcome. I want to know, does this drug lower hemoglobin A1C after 90 days? But if I'm doing that study, I might as well also collect fasting plasma glucose in the morning. I might as well also measure quality of life, how you feeling overall while on this drug. Maybe I look at subgroups, maybe men versus women differences, maybe men who are 30 to 40 years of age versus women 50 to 60 years of age. Maybe there'll be a difference. So the more sort of things you look at, the more likely one of those is going to have a difference based on what? Chance. Just by random chance. If I do enough comparisons, something's going to look different from something else just based on chance. So chance is always there, but we want to sort of not leave things to chance. And bias is always going to be there, and we want to try to minimize bias. Composite endpoints are a single endpoint in the study which combine multiple endpoints. And I think the example is sort of very beautiful to illustrate this. You see these in cardiology trials all the time. What it does is it increases your statistical efficiency, increases your power, ability to detect the difference. However, there's a risk that a single outcome may account for the entire outcome. And let me just illustrate this. You all learned about clopidogrel, Plavix. Plavix is, was, will be a great drug. Maybe. This was the big study published in the Lancet. So anything that falls on the right of this line, the Plavix is better. Anything that falls to the left of this line, aspirin is better. If it crosses or touches the line, what does it mean? No difference. So when you pick up a study such as the Capri study, looking at Plavix, you're going to come to this table, and you don't even have to know much more about the study. You can go right here. You don't have to read the methods. You don't have to read whatever. You can determine a lot of information. Stroke. Was Plavix better or aspirin was better? Plavix was better because it's over here, but it crosses the line, which means there's no statistical difference. So in terms of stroke, Plavix looks a little bit better, but statistically, when we put on our statistician's hat, no difference. So for those of you who said no difference, you're absolutely right. What about MI? What's better, Plavix or aspirin? No difference. Aspirin kind of maybe looks a little bit better, but statistically, no difference. Peripheral arterial disease. What's better? Plavix. So now they sort of combine, they add these patients plus these patients plus these patients, and guess what? It barely goes to the right. You can't see that there, but Plavix is better. And Plavix is better because of what? Its impact on peripheral arterial disease, which is arguably the least important of these three. But you see how they set up the study design where they report randomized blinded international trial to assess the relative efficacy of clopidogrel and aspirin reducing the risk of a composite outcome cluster. I mean, look at that, the composite outcome cluster. You want to be smart in life, you can make a lot of money working for, forget which company markets Plavix. And they did a composite outcome cluster of ischemic stroke, myocardial infarction, peripheral arterial disease, and they reported that clopidogrel was better than aspirin. So you can see sort of concerned with the gradient of importance, I call it. Endpoints of least importance to patients typically contribute to the most, benefit in that example. Soft endpoints should not be combined with real endpoints. What you want to do, you're better off reporting these three individually. But the problem is, this doesn't sound as sexy. It reduces peripheral arterial disease. It sounds sexier that it reduces the risk of a composite outcome cluster of ischemic stroke, myocardial infarction, or peripheral arterial disease. Subgroup analyses is when you look at a certain division within that total population. Examines the relationship between variables and smaller sets obtained from the original study. And all this statistical stuff we'll get to when we start to talk and focus more about the statistics. But the more subgroups you look at, the more likely one of those groups is going to show a difference based on what? Chance alone. So if we look at individuals, between 19 and 20 years old, between 20 and 21 years old, between 21 and 22, between 22 and 23, 23 and 24, some individual, some group is going to look different just based on chance alone. And actually, if you don't appreciate this, the way we do statistics, we typically look at a p-value of what? Less than 0.05. That means, and we'll look at that, what that means is if we look at 20 different groups, if we look at, it's a 1 in 20. So if you look at 20 different studies, one of which is just going to be wrong just based on chance alone. That's what that 0.05 looks like. So if we look at 20, and we'll report that all 20 are statistically significantly different, in all 20 groups there is a statistical benefit. One of those is going to be complete error. And we'll look at that. This is an example of subgroup. A study compared amlodipine and placebo in patients with severe heart failure. Okay, I want to know, does amlodipine improve patients with severe heart failure? Well, amlodipine did not significantly reduce death compared to placebo for the primary endpoint. Should be game over, right? However, they did report subgroup analysis in patients with non-ischemic cardiomyopathy determined amlodipine reduced the risk of death by 46%, with a 95% confidence interval of 21 to 63%. So, again, how do you interpret that? Amlodipine didn't improve patients with heart failure, and that was the primary study. That was the study. But because they also did this primary study, of course they're going to do some other studies in there, subgroup analyses. They're going to look at different orientations. And here they found non-ischemic cardiomyopathy. If that was the only secondary endpoint, I would be like, okay, not bad. I'll accept that. But what if they did 3 secondary analyses and one of which showed? What if they did 5 secondary analyses and only one showed a difference? What if they did 15? So you have to sort of interpret that understanding as a whole. And oftentimes, you know, you pick up the abstract and you just say, patients with non-ischemic cardiomyopathy, amlodipine reduced the risk of death. And your patient happens to have non-ischemic cardiomyopathy. So you say to the doctor, hey doctor, this drug is wonderful. It reduces the risk of death by 46% in your patient with non-ischemic cardiomyopathy. But it wasn't the primary endpoint. And the primary endpoint showed no difference. And if there was only one secondary endpoint, again, maybe it's compelling. But if there were 2, 3, 4, 5, 6, 7, 8, 9, 10 other secondary endpoints, maybe I wouldn't be so enamored by it.
What if another research study was implemented with a higher effect size? What if it actually increased or made it more significant?
Yeah, so, you know, absolutely. And again, you know, and I like that sort of understanding is research is just, it's a road. It's a highway. The car goes from exit A to exit B. And then the thought is that the next car will pick that up and go from B to C and C to D. And then you've got this whole sort of highway of research. Everything's building on everything else. You're getting more and more data, more and more information. And things change, as we kind of looked at last week. Surrogate measures we talked about are easily measured substitute markers used in place of more clinically meaningful endpoints, saves time and money. Something else, again, we sort of alluded to this earlier too, compliance. How many people here think a clinical research study of an active drug versus a placebo has 100% compliance? So again, what is sufficient? How do you define compliant? Have you guys talked about this in any of your social administrative behavioral courses? Because I don't know the answer to this. And again, you know, whatever textbook teaches you, there's a model that says this is compliant. I'm just the average guy. I got a hunch for what I think compliant is. But what's compliant? Because, I mean, again, I guess you can make the argument compliant is 100% compliant. You're either compliant or not. So then the question is, if that's correct, we're saying that 100% is compliant, what are we accepting? What are we okay with in terms of real life or in terms of clinical research? And are we less tolerant in clinical research? So in real life, if patients come to our pharmacy and they're taking 80% of their meds, are we okay with that? I probably would be okay with that. Maybe I would want 85%. But in a clinical study, I want 100% compliant. I want to know what's going on. Help me, patient. Take your medication at 8 a.m. every single day. And what happens if patients don't take it? You know, do you have still a placebo effect? Do you have a less of a treatment effect? All of that gets complicated. So how do you measure compliance? In clinical research? Basically, the question is, what do we do with sort of patients who are not 100% compliant? And typically, a study will say, we consider compliant 80%. So if patients took their medication 80% of the time, they were compliant, we included them. If they were less than 80%, we have to figure out what to do with them. Do we include them in the analysis? Do we include them in some of the analyses? We have to sort of look at that individually. And again, I think typically studies will have an 80%, which that's a huge non-compliance. So you got 20% non-compliant. And also, you know, I love this. I mean, how do you measure compliance? What's the best way to measure compliance in a study? The best way to do it is direct observation. So you want all those patients to come to your pharmacy, you know, at 8 a.m. every morning. Everybody line up with the pill in their hand, open their mouth, take the pill. We check you off. We'll see you tomorrow at 8 a.m. You didn't take your pill properly. Come see me after class. I mean, you can't do that. The problem with doing serum urine concentration is drugs don't properly fully correlate. It's very difficult to anticipate if someone's compliant or not based on what their level is. It's not like if they take their pill at 8 o'clock every day they're going to have a level of 8. If they take it every other day, they're going to level a 4. That's not the way things work. So serum urine concentrations are not typically used. What about pill counts? I give you 30 pills, you come back next month. Is that a good way? They could flush it, or they could take what? 30 pills on day 1. I got a really bad cold today. Let me take 15 pills today. Let me take 15 pills tomorrow. I'll come back in a month. I was so compliant, pharmacist. I got no pills to show you. That doesn't work. What about patient diaries? I want you to write down every morning that you take this at 8 a.m. Right, if they don't take the pills on time, they're not going to remember. So there they are, a day before their appointment. They go, yeah, I took this one at 8. I was a little late. I took this one at 8:04. I was a little early that morning. I took it at 7:59. I took every other one at 8 o'clock for the rest of the month. So that doesn't really work. Electronic counters are kind of neat. It's sort of, it opens from 7:30 to 8:30 every morning and it beeps. And maybe they can link it to a smartphone where your smartphone goes, take your medication, and then it'll sort of shut down and lock. So, again, how far do you want to go in terms of research? Oftentimes we do the pill counts. Cheap and easy. It sort of works, but that is definitely not perfect. Patient diaries, I don't think I could be honest with a patient diary. Electronic counter would work. Direct observation probably wouldn't work. Serum urine concentration doesn't work. I thought this was interesting. I came across this a while back. New research suggests that just changing the color of a person's pills by switching to a generic from a brand name drug, for example, sharply reduces the chance that the patients will continue to take it. Using a national database, researchers tracked prescriptions for 8 anti-epileptic drugs, noted patients who stopped filling them, and checked to see if the medication's colors had changed. In epilepsy patients, even short interruptions in medication can lead to a loss of control of seizures as well as serious medical, social, and financial consequences. Compared with patients whose pills remained the same, those whose pills' color was changed were 53% more likely to stop buying them. A change in shape also affected the patient's use of medication, but that was not statistically significant. So, again, patients are funny with their compliance. How do you measure compliance? How do you approach patients? This is an investigational drug for the common cold. They're supposed to take it for 10 days. What happens after day 4 when they wake up feeling great? They're probably going to stop taking it. What happens when they wake up on day 4 and feel like crap? They're probably stop going to taking it. So, again, there's all kind of psychological issues that go into this. And if this is an interest to you, there's plenty of research pharmacy opportunities for that. The next issue is the duration of a study. How long do you set your study up for? You should provide sufficient time to detect the outcome of interest that reflects sort of real practical use. And this is what I love too. You look at anti-hypertensive studies, anti-diabetic studies, anti-hypercholesterolemia studies. Typically the studies are 4-6 weeks, 8 weeks long. How long do patients have diabetes, hypertension, and high cholesterol? Longer than 8 weeks. Probably forever, for the rest of their life, oftentimes. So you can't do a study for the rest of patients' lives, can you? I mean, that's sort of impractical. But 8 weeks sounds pretty impractical. Also, it seems pretty short. So you have to figure that out. What happens to the disease state? Tachyphylaxis, oftentimes you develop sort of an intolerance over time. The drug just sort of stops working. Or regression towards the mean is an absolute statistical matter where patients over time will just regress towards the mean. Whatever their blood pressure is, the amount of high blood pressure, they'll get some sort of maybe lack of responsiveness, but they'll also just go back towards the mean. And then something else, which is sort of my own personal interest, is the assessment and reporting of adverse effects in research. And we'll look at this after the midterm. I do a whole study on this. It's because, again, we're so focused. Let me look at the primary outcome, amlodipine versus placebo in 8 weeks or 12 weeks or 26 weeks. And then we also did a subgroup analysis, and we figured out that patients with non-ischemic cardiomyopathy have a 43% Does anyone talk about, well, what about the side effects? Do the drug cause side effects? Were patients compliant or not? What's the cost of the medication? So you have to take all that into account. And an IRB should look at that. And then what's the ethical and legal requirements? What happens to someone who takes a study drug and they get injured? Who should pay for that? Should the researcher? And the answer, we kind of talked about this in pharmacy law, the researcher really shouldn't be on the hook because somebody's going to get injured somewhere along the line. And you know, the researcher, if they don't know the risk, they shouldn't be responsible for the risk. But they have to properly disclose everything through the informed consent process and have patients sign their rights saying, you know what, I could be injured. And if I'm injured, I have to take care of myself. You may have a study where, and we deal with this at the NSU, Nova Southeastern University, IRB all the time. You know, if we're giving patients some sort of medication, we as the university, you know, we want to make sure our patients are protected. But we also can't expose the university to unlimited liability. But this is a struggle. You know, how can we make sure that patients? And then registering and publishing the clinical trials. What happens? You do a great study. You show that vitamin C12 doesn't work. Should researchers be required to report that, to publish that? There's some argument that they should be required. But you know what? If it's my own personal money, I've spent my own personal time developing vitamin C12. I think vitamin C12 is going to work. And vitamin C12 actually is really harmful and patients die. Should I be required to publish that? Required to publish that, even though it's my own money, my own data? Again, it's a good argument. Patients get injured, but I would sort of counter too. This is my information. I made a deal with individual patients. I'm going to give you $50 a month to be in my study. You want to be in the study? I'm going to give you a drug. You're going to take the drug. You have the common cold. I'm going to measure your common cold. Oh, you died? That's bad news. But nowadays, the FDA has moved, sort of since 2008 as part of their public access policy. Essentially what happens now, the FDA, if they're going to research, if they're going to look at it for the drug approval process, or the FDA is going to have access to that data, they want it published. And the NIH, National Institutes of Health, if they pay Dr. Clark to do a study studying vitamin C12, the NIH requires, because it's the government funding, they're going to say, you take our money, you're going to have to publish those findings, either in a full-scale journal or at least make it available through some sort of registry. And a great example of this was Convince. This was a study, I think it was an antihypertensive drug, and patients were in the study for 4 years. Everything was going good. And then the investigators said, well, there's a commercial interruption. We're no longer going to finish the study. We're no longer going to publish the data. And again, if that sounds a little fishy to you, it sounds a little fishy to me, you can Google the Convince study and find out what happened. Basically, they said, oh, we ran out of money. We're not going to finish the study. We're not going to publish it. And guess what? If that drug worked really, really well, I don't think that would be the same case. So, you know, that happens in research. We'll go ahead. We'll take a 10-minute break, and we'll look at our pyramid of study design and strength of evidence. All right. Any questions from the first hour in Palm Beach? Or any questions on anything thus far? Any questions from San Juan?
No questions.
Wonderful. What do we have? One student and a shark up in Kendall? Any questions? This pyramid sort of ranks the strength of the evidence of the different research studies that are out there. The best type of research study is what? Top of the pyramid. Randomized control blinded studies. That is the best type of data that's out there. Does that mean that that's always the preferred study design? No, it just means it's the best type of evidence. A lot of what we talked about, we looked at this last week. Causality. How do we get to causality? How do we say something causes something else? The higher we go up here, the more likely we are to say that with confidence. So randomized control blinded studies versus just randomized control studies versus just randomized studies. Each time you lose something, you gain more bias, more likely to have some reason that something is viewed that way that's not based on the evidence. We'll look at cohort and case control studies. These are observational studies. So you've got your interventional, your observational, and then your descriptive. Descriptive is just, this is what I reported. Observational is, we're doing a planned study, this is what we're going to see, and randomized control prospective studies. Case series, case reports, ideas, editorial opinions, animals, in vitro research. So, one of the challenges with animal research is how do we extrapolate that to humans? One of my really close friends in pharmacy school, he found that some chemical product extended the life expectancy of rats by like 1,000 lifetimes. So my friend started to buy this chemical through the web and was taking this, convinced that he was going to extend his life 1,000 times. And that was the same friend that ended up stealing narcotics from his Rite Aid pharmacy and overdosed in the ER. He lived and survived, but he was crazy. Good friend of mine. So, again, just because something happens in animals doesn't mean that it relates back to humans. So randomized control trials are gold standard research design. Everybody should just know that, period. No problem with that. Randomized, double-blind, placebo-controlled trials are the gold standard research design. Evidence-based medicine, FDA approval. What happens, you take a sample from the population. So up here you got the population. We can't study the whole population. We do a sample. We randomize patients to get either the active medication or a control. It could be a placebo control. It could be an active control. It could be a historical control. But we're randomized people going forward in time. So this is a timeline. We're moving forward. You measure the outcome of interest, plus or minus, the control group. You compare differences. You make assessments, determinations, and move on. Publish that. So here, if we're looking at vitamin B12, maybe that's our control versus vitamin C12, or maybe we'll do vitamin C12 versus placebo. We want to know your cold symptoms get better or worse, your cold symptoms get better or worse. And we compare those differences. And if the active drug has a greater improvement of cold symptoms, the active has greater resolution of cold symptoms versus the control drug, then we make that determination based on statistics. It's the strongest design to assess causality, allows us to limit bias with Ghostbusters, however, expensive, difficult to perform, and ethical concerns. Don't worry about this right now, but within randomized controlled trials, there's called superiority trials and non-superiority trials. Typically, what you think of as a randomized controlled trial, we're testing vitamin C12 versus vitamin B12 to see which is better. But more and more studies are doing this whole thingamajig, non-superiority to trial to test if one therapy is similar to or no worse. So we'll show that vitamin C12 is no worse than vitamin B12. And we'll look at this in more nuance after the midterm. And this is just, again, all the companies, they do study designs to hedge their bets. We talk about $1 billion industry. If you can show something is better than something else, you are at a great advantage. Yes? No. No. The statins, that's just based on the bioequivalence. It's not this. This is just a randomized controlled trial. But we say that vitamin C12 is going to be better than vitamin B12. We understand that. We're going to look at whatever outcome, a cold survey, whatever it is. Here, it's not showing that it's better. It's just showing that it's no worse than, which is a very subtle difference in terms of semantics, but a huge statistical difference in terms of how the study design is assessed and determined. So here they may say that vitamin C12 is better than vitamin B12. That's wonderful. But here they say vitamin C12 is no worse than vitamin B12 or similar to. And if vitamin B12 is sort of the gold standard and you can show that you're similar to and no worse than, because if you don't think that you can show that you're better than, and this is even easier to show that you're similar to because you can set up sort of a big window that even though I'm worse than them, I'm really no worse than because I've had such a huge comparison. So again, we'll look at this, but you'll often see this in study design, non-superiority trials, non-inferiority trials. We're not inferior to that drug, but you kind of are, kind of like that Plavix study. Well, you're kind of worse, but you're showing a huge window, so you're within that window. So if you're looking at Me Too drugs, a new type of statin, it may be beneficial. The only thing, again, I just want to, so you're going to, superiority trials, you're better than the comparative. Non-superiority, also known as non-inferiority, that you're no worse than, you're similar to. So yes, the Me Too drugs may have that. What they're trying to do is, again, hedge their bets, showing that their drug more likely is going to have a beneficial, and I use beneficial in quotation, beneficial impact. Somehow that there's some benefit to what they're doing. Pilot studies are small studies. Mini studies of a full-scale study, also called feasibility studies. In the purest sense, pilot studies do not require IRB approval, in the purest sense. Why do they not require IRB approval? Because you're not doing research. You're doing a feasibility study. You just want to see how the study design works. I just want to see, do patients take their medication? How long a run-in phase do I need to have? What's my outcome of interest? Because, again, research is defined as generalizable approach, a systematic approach intending to lead to generalizable knowledge. But you'll often see pilot studies, mini studies, feasibility studies, kind of just that first step into the research. And again, beware of false conclusions or assumptions, because if you do a pilot study and you show that your vitamin C12 is better than vitamin B12, it's just a pilot study. I just wanted to see the feasibility of my study, see how patients are going to respond, see if this double dummy is going to work, see if a 6-week duration is probably an okay duration. And then I'm going to power my study properly. So it's feasibility studies. Cohort. A cohort is a group of subjects who have not yet experienced the outcome of interest. It's just a group of individuals. A cohort is a group of individuals. A cohort study is I'm going to follow that group of individuals prospectively over time. So we looked at observational studies, we looked at interventional studies, and we looked at descriptive studies. Interventional, which of the following are interventional studies? Randomized controlled trials? Yes or no? Interventional, yes. What about a non-inferiority study? Non-superiority study? Is that interventional? Am I giving an intervention? Yes. What about a crossover study? Yes. What about a parallel study? Yes. What about a cohort study? Cohort study, not interventional. I'm just observing these people. I've got a group of individuals and I'm watching them over time. The classic example of this is the Framingham study. Anybody ever hear of Framingham? Framingham risk factors? Have you learned that yet? In your lipids, pharmacotherapy, Framingham. Anyone know what Framingham means in Spanish? Doesn't mean anything in Spanish. Framingham is a city outside Boston in Massachusetts. Framingham is a place. You can drive to Framingham, you can fly into Framingham, you can walk into Framingham. It's a place. They decided to get all these people in the study together, in the city together, and say, guess what? We are going to study you for the next 50, 60, 70, 80, 90 years. We're going to study you, we're going to study your children, we're going to study your grandchildren, we're going to study your great-grandchildren. And we're just going to watch you over time. And that's what happens. They bring in these people from Framingham, and they say, you eat a lot of fried food? Okay, yes or no. You smoke a lot? Yes or no. You have diabetes? Yes or no. Do you die prematurely from your diabetes? Yes or no. And then they figured out what? Patients who ate a lot of fried foods, who smoked a lot, and had diabetes happened to die sooner than patients who didn't smoke and didn't eat fried food and that had diabetes. Or the patients with diabetes live longer or shorter than patients without diabetes. They just monitor these people over time. It's non-interventional. Cohort is a group of subjects who have not yet experienced the outcome of interest. So we're going to measure something on them. We're not intervening, we're just observing. Subjects exposed to a factor of interest are compared to a control group not exposed and follow prospectively. So subjects exposed to a factor of interest, people who smoke, versus a control group that didn't smoke. And guess what the study showed? Patients that smoked did worse. And they were able to break it down into those risk factors that certain types of patients, based on a certain score, did better or worse and require a certain intervention. But again, this was an observational study. So here's your study, your group of people in Framingham, Massachusetts. How many of them smoked? How many of them didn't smoke? How many of them developed lung cancer? Didn't develop lung cancer. How many people didn't smoke, developed lung cancer? How many people didn't smoke, didn't develop lung cancer? So then you can compare these and say, guess what? People who smoked were more likely to develop lung cancer than people who didn't smoke. And the original Framingham study was based on cardiovascular health. So a lot of their data is built around cardiovascular health. And then they not only had that group of individuals, they had the next cohort, their children, and then they have, right now, they're at the third cohort, the grandchildren of those original individuals of Framingham. Cohort studies are good because they allow a temporal relationship. We know what happens over time. Perhaps when a randomized controlled trial is infeasible or unethical, do we want to have, 50,000 people smoke cigarettes and 50,000 people not smoke cigarettes? Who's going to pay for that study? It's easier just to compare all these people, bring them in, give them a whole interview. Oh, you happen to smoke, you happen to, eat whatever fried foods on Thursdays, and you smoke marijuana on Wednesdays. You have all that information. The problem is it's less controlled. So if someone says, yes, I have diabetes, or yes, I smoke cigarettes, someone who smokes 1 pack of cigarettes a day is different from a person who smokes 1 cigarette every week when they go to the bar. Or who smokes, chain smoke 3, 4, 5 packs a day for 5 years, and then they no longer smoke. So all of these sort of things, expensive, time-consuming to perform because it's over long periods of time, lost to follow-up. What happens when people moved out of Framingham? Maybe they moved to Honolulu for a new job. They're probably lost all that data. But again, what's beneficial is you've got a large group of people available to you. Framingham was originally initiated in 1948, part of the National Heart, Lung, Blood Institute of the NIH. They originally had 5,000 patients, and now the third generation, over 1,200 research publications came from Framingham and still continue to. This was just the data that I've showed. This is only 3 years. We've got 300 studies in 3 years. So 100 studies are coming out per year, at least during this period of time. You've got, just an enormous amount of data coming from Framingham. Framingham is a classic example of what type of study design. Cohort. Is that a prospective or retrospective study design? It's prospective. Is it observational or interventional? It's observational. We're just observing people going forward over time. That's the cohort study. You've also got a case control study, which is called a TROHOC. Anyone see anything funny about the word TROHOC? It's cohort backwards. So now we're taking that group of individuals and we're looking at them retrospectively. So case control studies are retrospective studies. Useful for studying rare diseases or adverse effects. And this is sort of the setup. This morning I looked and there were two examples of case control studies that I thought were illustrative. One, it had people who had an MI. They wanted to know how many of them were overweight versus how many of them were not overweight. And they compared that to certain individuals who didn't have an MI, and they looked at if they were overweight or if they weren't overweight. And the thought was, the hypothesis is patients who had an MI were more likely to be overweight. So they're going back in time versus a cohort study is going forward in time. The other example was a drug called pseudoephedrine. Pseudoephedrine is phenylpropanolamine. Phenylpropanolamine was a product that was in every cold and cough medicine when I was a child growing up. Phenylpropanolamine. There was a concern that phenylpropanolamine caused hemorrhagic stroke. It's a rather rare side effect, hemorrhagic stroke in patients with phenylpropanolamine. So do we want to set up a randomized controlled trial for that? First of all, you've got the ethics involved. I'm going to give 1,000 people phenylpropanolamine to see if you develop hemorrhagic stroke. That doesn't sound good. And then the other issue is, okay, say an IRB approves it, I'm going to give 1,000 people hemorrhagic stroke. Hemorrhagic stroke occurs in 1 in 10,000 patients. Not only, is my 1,000 patients probably insufficiently powered, now I have to get a large group, I have to follow them over a long period of time. And then the other question is, what else causes hemorrhagic stroke? Well, maybe smoking causes hemorrhagic stroke. So now I have to find patients who I will give phenylpropanolamine who have to make sure that they don't smoke and they don't take anti-obesity medication, or they don't have to take any sort of adrenergic drugs. So what they did here is they set up a study. They found those with hemorrhagic stroke, and they look at, did you take phenylpropanolamine? Patients without hemorrhagic stroke, did you take phenylpropanolamine? And they're able to compare those differences and show that patients who have hemorrhagic stroke were more likely to have taken phenylpropanolamine as opposed to those who never had hemorrhagic stroke. So one of the issues you see, how do you sort of set up a control group? How do I find patients who had hemorrhagic stroke, and how do I compare those to patients who never had hemorrhagic stroke? I want them to be what? The same age, live in the same area, go to the same school, drive the same car, wear the same shoes. Ideally, that would be a great control group. So again, you're going to compare those two groups to see how close was this. I just think this was interesting. They talk about recruitment of control subjects. We attempted to identify 2 matched control subjects to each patient through the use of random digit dialing. So based on people's phone numbers, area codes. Matching criteria included telephone exchange, sex, race, and age. When a perfectly matched control could not be located, we enrolled an imperfectly matched control rather than excluded the patient from the study. So now they had a patient with hemorrhagic stroke and they couldn't get an exact match. So they did, when a perfectly matched control could not be located, we enrolled an imperfectly matched control. So you could see all these sort of problems. And then how do you really know if they took phenylpropanolamine? You have to interview those. Well, I took phenylpropanolamine every morning because I take phenylpropanolamine every morning. Or maybe I don't know phenylpropanolamine. I mean, I had a couple of colds. I took some medication. I don't remember what I took. Actually, I don't even remember if I took it. I remember my mom offered it to me, but I don't know if I actually took it. So you can see sort of all these issues, and that's why observational studies give us good information. However, they've got lots of imperfections. Case control is more biased, one, because it's retrospective. Retrospective studies are more biased than prospective because you have less control over the influence. However, it's an efficient use. It's a low cost, useful studying rare occurrences, no loss to follow-up, and it's an ethical study design. So case control and cohort are observational. Cohort is prospective. Case controls are retrospective. You've got cohort, loss to follow-up is a problem. Recall bias is a problem for case control. And the statistics, when you see relative risk, it's a cohort study. Or if you do a cohort study, you compare relative risk. The relative risk of dying from smoking, dying from a heart attack, is 95 whatever relative risk to people who didn't smoke versus the odds. The odds of a patient getting hemorrhagic stroke having taken phenylpropanolamine is higher than patients who didn't take phenylpropanolamine. So just sort of another depiction of what that looks like. Cohorts, forward over in time, case control, TROHOC studies backwards in time. Case reports and case series were lower down that pyramid. Now we're into descriptive. We went from interventional studies, the greatest type of study design, then we went to observational, and now we're in just descriptive studies. Just a descriptive account. This is a picture of phocomelia, which was associated with thalidomide. This is a thalidomide baby. And again, it doesn't show that patients who took thalidomide had a fetus with phocomelia. There wasn't a randomized control study. There wasn't an observational. We didn't go back and look. We're just describing this patient had phocomelia. This patient's mother took thalidomide. We could do a case control study, find out patients with phocomelia, patients without phocomelia, patients with phocomelia, did their moms take thalidomide? Patients without phocomelia, did their moms take thalidomide? And we can compare differences. Case series are just a number of case reports. So I have one case, but then the CDC may just publish there were 5 babies born this year with phocomelia. 5 babies born with phocomelia. Last year we had 1. All 5 patients in the United States, their mothers took thalidomide. Do we know that thalidomide causes phocomelia? No, it's lower down that pyramid. It's sort of hypothesis generating. Well, maybe I need to do a study. Maybe I need to do a case control study. Maybe I need to do a randomized control study. And in that example, for those of you who said yes immediately, that phocomelia causes, or thalidomide causes phocomelia, you're not understanding the nuances of statistics. And this was a great example of a book I was reading, and I'll talk about this also in the adverse drug event lecture. There's a drug called bendectin. I forget what the actual drug is today. It's available again. This was a drug that was off the market for 40 years. Way back when, in the 60s, patients took bendectin. There was a concern that their children were being born with fetal abnormalities. And there was a woman who had a child with a fetal abnormality, and she happened to take bendectin. Does that mean bendectin caused the fetal abnormality? Statistically, absolutely not. I don't know what the statistics are, but there are hundreds and thousands of babies born probably every day that have fetal abnormalities. So what happens if you take Bendectin and you have a child that has a fetal abnormality? Sure, that could happen. But was it associated with the Bendectin? Maybe, maybe not. For patients who don't take Bendectin have fetal abnormality. So this was sort of a big issue that Bendectin in this example actually didn't cause fetal abnormalities. The drug, there was so much data to show that it didn't. Statistically, it did not cause fetal abnormalities. But try telling that to a woman who took Bendectin and now has a child with a fetal abnormality. What is she going to believe with all her heart and soul? That drug caused that side effect. It makes sense. But statistically, it didn't show that. So the company, as opposed to dealing with these lawsuits for 30, 40, 50 years, they just decided to pull the drug off the market. They said, we don't need this headache. We don't need this bad PR as a pharmaceutical company. We don't need a woman to, walk into our elevator saying that we caused this problem. And amazingly enough, the drug was just reapproved in the last year or two under a different name. It's used for morning sickness. But you can't make clinical decisions based on this, or you shouldn't make clinical decisions because there's no causality here. Yes? Right. Animal studies are not case reports. So, again, animal studies are further down that pyramid. The case reports are typically the human studies that just report something. And we do case reports all the time. Patient takes vitamin C12, their common cold went away. Okay. Now, does that mean that vitamin C12 cures the common cold? The answer is no. Not based on that. You have no idea. You have to do the research study. You would want to do a randomized control study. So here you've got randomized, better than cohort, which is better than case controls. And we know that double-blind studies are better than single-blind versus open-label studies. So just another depiction. You should be able to fill in those areas of the table. Review articles, people write them all the time. There's two types, qualitative and quantitative. Did you guys learn about meta-analyses? A little bit. So meta-analyses are quantitative analysis where you're actually doing quantity. You're doing numeric. You're doing mathematics. You're using numbers. Versus qualitative review articles, systematic reviews. So a good example of this maybe is, does marijuana have a beneficial impact on migraines? Does marijuana impact migraines? I can do a systematic review. I'm going to set up a review. I'm going to study only those that use actual marijuana. And I'm going to set up studies that have only studied it for at least a 10-week duration. Or patients that had true migraines with or without aura. So I can set up the criteria, I can do a literature search, and then I can report on that. So marijuana appears to have a beneficial impact on patients with migraine. What's the problem with that? With that article, with that publication? It's got my own what? My own bias. And as much as I want to be unbiased, as much as I want to set up the criteria, the systematic approach, there's bias in me. It could be bias for or bias against. I could start off with bias for, and I can end up bias against at the end. But systematic reviews, also qualitative reviews, are just I found 10 studies, I looked at them, I think marijuana may or may not work. The problem is there's no statistics with that. Statistics are everything if you don't appreciate it. It's why you pay for your car insurance. It's how you get graded on an examination and determine eligibility for remedial. All of that. Then you've got meta-analyses, our method of statistically combining the results of previous and similar research. Meta-analysis, easiest thing to understand, a study of smaller studies. I just take a whole bunch of studies together, I put them in a blender, I mix it up, and I get one big study. Essentially, I take all the patients from all the little studies, and I just come up with my own big study. The problem with that is the chain is only as strong as its weakest link, and if one of the studies is bad or one of the patients is problematic, that may contaminate your study. And we'll look at this. So why do you do meta-analyses? To resolve conflicting data. Some people think that marijuana is good for migraines. Some people think marijuana is not good for migraines. 5 studies have shown it's beneficial. 5 studies have shown it's not beneficial. So 5 studies have shown marijuana is beneficial for migraine. 5 studies have shown it's not beneficial. So if there was an exam question, true or false, marijuana is beneficial for migraines. I don't know. You got 5 that study for, against. So what you may do is a meta-analysis. You may want to take all those 10 studies together and see where you fall. And we'll look at sort of what that looks like. Inconclusive results demonstrate significance among subgroups. So maybe in different subgroups, you've got different populations. So again, we like meta-analysis, but as I mentioned before, the more things you look at, the more you combine, the more you interpret, the more likely you are to have bias and more likely to have the impact of chance. This is the Cochrane collaboration. You may or may not have heard of them. They're a group that does essentially meta-analyses, systematic reviews. They take studies that are out there and they combine them to do meta-analyses. Just thought this was interesting reading. The Cochrane, the circle, the logo, the circle formed by the 2 C's represent our global collaboration. The lines within illustrate the summary results from an iconic systematic review. So this was a study that they did. Each of these was the result of a study. And if it crosses the line, you have what? No difference. If it's to the left of the line, it looks like it's worse or less. And if it crosses on this side, it looks like it's more or better. So here they looked at the impact of corticosteroids on premature survival of preemie babies. Did giving systematic corticosteroids increase survival? So the left side is less people died, less babies died. So in this study, some less babies died. In this study, no difference. In this study, if it touches the line, no difference. But it looks like there's sort of a trend. This study clearly didn't show a difference. This study showed no difference. This study did show a difference. This study, no difference. So does the impact of corticosteroids reduce the risk of premature death of newborns? Well, in this study it did, and this study it did. No, this study it did, this study it did. But in this study it did not. Well, this study did not, this study did not, this study did not, this study did not. So they added all those together, and they found that was where the point is. And they report that, this has saved hundreds of thousands of premature deaths, administering corticosteroids at wherever point of childbirth. But, they had plenty of studies. They had 1, 2, 3, 4 studies that showed no difference, and 2 big studies that showed a difference. And they added them together, and we decided that there is a difference. Aminoglycoside, is there a difference 3 times a day dosing versus once daily dosing of aminoglycosides? There's no difference. They added all these up, so maybe this is once a day on the right side, this is 3 times a day on the left side. No difference, no difference, no difference, no difference, no difference, no difference, no difference. Again, pretty obvious, all those studies, no difference, but they added them up, sure enough, absolutely no difference. Amiodarone and sudden death. Does amiodarone cause an increase in sudden death? Here it showed decrease in mortality, but you did the meta-analysis of all these studies, it showed a decrease in mortality. So amiodarone was useful. But this study showed no difference. 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 Difference, no difference, no difference, no difference, no difference. All of those, you add them together. A meta-analysis is a study of smaller studies. The strength is it's statistically robust. You've got a lot of patients, great utility, clinically relevant. It answers your question. However, the bias and flaws of the individual studies you can't eliminate. You can try to control them. What happens in one study, the patients were 30 to 40 years old. Another study, the patients were 45 to 55 years of age. So you got 30 to 40, 45 to 55. How do you sort of, okay, what happens to patients who are 30? Can you use that other information? Perhaps not. What was the dose? All the studies have the exact dosing. So you've got the garbage in, garbage out problem. Some of the studies are combining apples and oranges. And then what happens if some of the studies are incomplete? You want to use those in your meta-analysis. Because again, meta-analysis are good because it's more robust. You're getting more and more data, more and more numbers. However, if one of those is incomplete, what do you do? Another type of study design out there is cross-sectional studies. And we looked at cross-sectional data collection, meaning just a snapshot in time. And cross-sectional studies are just studies taking in a certain period of time. How many people here have the common cold? 10. How many people here take vitamin C12? 0. Therefore, vitamin C12 has no impact on the common cold. Again, not a very good study design. Is that interventional? Is it observational? Yep, just observing. And the thought is that we want to try and extrapolate this. Again, we're a descriptive study. We're just describing something. We're not trying to assess causality. But if we assess causality to it, it becomes observational. And here's the subjects, yes or no. Did they have the outcome? Did they not have it right now? It's a weak study design, but again, all of these studies, every type of study has its place. And you may or may not want to use this in your clinical decision-making process, but they all have a use. Cross-sectional studies are typically useful for generating and testing hypotheses. They're inexpensive, easy to perform. Transient effects is, again, people get colds last week, not next week. Difficulties in error in data collection, no determination of causality. Survey research. Research used to study the incidence, distribution, and relationships. Most people here probably received a survey at some point in their life. Do these have a good response rate or a poor response rate? Typically a poor response rate. I don't want to be bothered filling out a survey. So how can you get a better response rate of a survey? Keep it short. Rewards, incentives. What's a good reward? Money. Again, and we looked at that from the IRB perspective. So if I'm going to give you a survey of the best pharmacy professor in the college, and I'm going to give each of you $100 and a guaranteed A, just because I want you to fill out the survey. How many people want the $100 and the guaranteed A just to complete this very short survey? Just write down the name of your favorite professor. And I'm just going to walk down the row. I'm going to hand you the $100 when you fill out the survey. Is that okay? So, again, surveys have really poor response rates. How do you improve it? All of those things. If I just send a generic email link to people, am I going to get a good response rate or a bad response rate? If it's something that people aren't necessarily committed or impassioned to, probably going to get a poor response rate. It's easy to perform. It is very scientific in terms of it could use a validated instrument. It could provide data that I can compare. I can know, again, what's the age of the individuals, what's the race of the individuals, what's the zip code of the individuals, so I have good comparison information. There doesn't seem to be a lot of incentive to lie on a survey. I mean, that example, I would, well, Dr. Levin is a much better professor than Dr. Seaman. I'm going to put her name down. That's fine, but, an example of which route do you take to school in the morning? I'm going to screw up the survey. I'm going to tell them I take the back road when I take the main road. Not a lot of incentive to sort of cheat or lie. But who I sample, if I got the people that are here in class today, You probably live closer than individuals who live further away from the campus, which may take a more alternate route or whatever. Low return rate, low response rate. It's sort of, very difficult, if not impossible, to assess causality. Then you've got N of 1 studies, which is just a randomized control study involving a single subject. It's sort of a randomized control crossover design of a single subject. So now I have an individual that has a migraine. I want to find out what's best for that patient with a migraine. So maybe I blind them. I give them here. Go home and take this pill. This is Imitrex. We'll see how you feel. This one's a marijuana pill. See how you feel. This one's Excedrin. See how you feel. This one's a Vicodin. See how you feel. So maybe I give it to them randomized. They take each one for a week. I see them every week, and they're like, okay, whatever that second week was, that felt great. My migraine went away. And then when I went to the third week, I started taking the third medication, my migraine came back. So you'll infrequently see randomized or N of 1 trials. But again, it's another way to assess causality. And thinking through too, this course and these lectures, they may seem redundant to you. Maybe you've seen some of the stuff. And it's not here to really teach you how to go out and do a study. Again, it's meant to sort of prompt you on how to think through issues. If you're going to set up a study, whatever that study is, maybe me as department chair, I want to find out who the best faculty member is in my department. So, I can come here and maybe survey, because if I take my name out of the hat, what's the incentive for me? It doesn't matter if you say Dr. Levin or Dr. Steinberg. It makes no difference to me. I'm just curious. Versus, if I keep my name in that, it's going to be very different, because people here who think that I want a good response, they're going to get benefited, are going to write my name. People think, I don't like Dr. Seaman. If he wants to play with me, then let's go. I'm going to put anybody but him, and if he comes try to fail me, I'll take it to the dean. So, again, or maybe, how do I get data? Is that the best way to do it? Should I just send an email to the whole class of 2019, 2018? Should I just email the class saying, who's the best professor, fill in the box? Or should I take the 3 top professors, which I know are the 3 top professors? And what's the problem with that? So N of 1 trials are easy to perform. Does not typically require IRB consent, because you're not generalizing that to other populations. I want to treat this patient. Useful for randomized controlled trials are not feasible. However, you've got crossover effects, which you're going to have that washout period required. Again, we talked about that. So between each treatment, I may want to wait 5 half-lives. So that means that the patient is not treated for those 5 days or 5 weeks. Lack of generalizability, lack of control. We'll go ahead, answer any questions or take a break. We'll look at pharmacoeconomic and outcomes research, and then we'll jump into the statistical part next week. Any questions about different study designs, different elements? I will work to post this lecture today or tomorrow, as opposed, in addition to last week's. So thank you for your patience. You have exams this week? Tomorrow? Pharmacotherapy? On the bottom, put Dr. Seaman's the best professor. See if they get you more points or less points. Good luck. Have a good day. Thank you.